To the July Innsbruck Table Talks. This is an event that has been going on in Innsbruck for a very long time, though we rebranded it. It used to be the Executives Breakfast. And we rebranded it because we wanted it to be more conversational. We wanted to invite folks to.
Hey, buddy. Sorry, I'm right in the middle of something.
I think you just muted yourself.
Have I been talking to myself all the time?
Just for 20 seconds.
Oh, nothing new there. Anyway, welcome to the July Table Talks, Innsbruck Table Talks, an event we rebranded a few years ago so that we could invite more of a conversational format. And when we did that, we certainly did not know that in 2020 we would be looking at all of these beautiful faces and really having the only way to communicate in this way safely with this number of people. And we're just grateful to be able to have you join us and support us even via Zoom. And so today we're very, very lucky to have Dr. Danny Avula. And I just want to read a little bit about Danny before we get started. If you have not met him, then you need to find a way to meet Danny. He's such a wonderful person. But in addition to that, he is the director of the Richmond City and Henrico County Health Departments. He is a public health physician specializing in pediatrics and preventive medicine, and he continues to practice clinically as a pediatric hospitalist. After graduating from the University of Virginia, he attended medical school at the VCU School of Medicine and completed residencies at VCU and Johns Hopkins University, where he also received a master's in public health. He is an affiliate faculty member at VCU, where he regularly serves as an advisor and preceptor to graduate and medical students. He was appointed by Governor McAuliffe to the State Board of Social Services in 2013 and served as board chair from 2017 to 2019. He is also the immediate past chair of the Richmond Memorial Health Foundation and serves on many boards. And he is also a humanitarian award recipient of the Virginia Center for Inclusive Communities Humanitarian Award and the 2019 Richmond Times-Dispatch Person of the Year. Please welcome Danny Avula, Dr. Danny Avula. Show your love. You can use all these fun emojis down. I'm an emoji freak, so I'm always, finding an excuse to put up some kind of emoji on my screen. But we do want to definitely welcome Dr. Avula. Danny, so great to have you with us today. I think we're going to we're going to try to highlight the two of us so we can show the conversation. I think Stephen is working on that. But in the meantime, we're going to dive into some health subjects. It occurred to me that, it's not as though we're not concerned with health other times, but I think our focus has been drawn to health concerns in a way that is far and away more than maybe in the past. Maybe you work out, not you, just people work out, maybe you don't, maybe eat healthy, maybe you don't. Take your vitamins. A lot of people forget that's even a thing. And now we're all like, okay, how do we protect ourselves? So we've got a lot to talk about in that regard. But I wanted to also talk about you when we start. And I've got this picture. I don't know if anybody can see it because of the virtual, probably not. Anyway, it was in the Richmond Family Magazine, the summer 2020 edition. And you are featured in there with your beautiful family. My goodness. You have your hands full, sir. So tell us a little bit about you, if you would, please.
Sure. So where to start? I have been in the public health world for about 11 years now. I realized at some point in med school that while I knew I wanted to be engaged in health in some way, it wasn't necessarily through the direct, individual clinical care that most physicians spend their lives doing. And I just, I came here to Richmond to go to medical school back in 2000. And there were a lot of really great things about my experience, but I also recognized that particularly in my interactions with lower income patients, that the impact that I was hoping to have on people's health was going to be much more complicated, because the lives of people, particularly people in poverty, are really complicated. And so that sort of feeling continued as I progressed through medical school, and then I started my pediatrics residency, and just found myself seeing patient after patient talking about things like better nutrition and exercise, and seeing families kind of look at me with blank stares. And it was because, in my youth and naivete, I had no insight into what my patients were facing in their daily lives. We would talk about healthy nutrition options for their kids, and parents are thinking, I'm just trying to get put one foot in front of the other, get food on the table, make my food stamps until the end of the month. We would talk about exercise and in many communities in our region, parents just don't feel comfortable sending their kids out to exercise, or there aren't youth programs that are readily accessible. And so, I think those are as two small examples of where the impact on an individual and a family's health goes far beyond what medicine I prescribe them or what guidance I give them in the office. And so I started to really be challenged by these macro issues driving the health of a family and the health of a community. And so late in medical school, I discovered public health. I remember actually third year medical thinking, this is for me. I should probably quit med school and go find something else to do. And my wife, who is definitely the wiser of the two of us, you got a year left, get your degree, we'll figure it out. It was great because it forced me to kind of explore other pathways that a physician could, ways that a physician can contribute outside of direct clinical medicine. And so I discovered public health. I realized my fourth year of med school that is what I wanted to do with my career. After I finished my pediatrics residency, I went and did a second residency in preventive medicine and public health. And for me, I would say that is the first time in my educational pathway that I really came alive. The coursework around the master's in public health, the residency training in preventive medicine was just so energizing in a way that much of my education path had not. So it really felt like an affirmation and a calling. And right at the end of that residency, an amazing job opportunity opened up as deputy director at the Richmond City Health Department, and that's where I started in 2009. Back in 2016, became the director, and then I've had the great fortune to work with colleagues in Henrico and to actually become a shared director of both the Richmond and Henrico Health Departments. So it has been a ton of fun and never more challenging than the last 5 months. Without a doubt. I mean, this has been the most, shaped all of our lives and run all of our lives in every way. And so I think that is definitely true for public health. Yeah, so I'll pause there. But maybe more on the family side. My wife and I have been married for 19 years now. We have 5 children, ages 19 to 8. They have, in some ways, been loving this COVID life. I think that not having the grind of school, they've really appreciated. My wife, who is also an educator, she's an elementary school teacher, she has definitely sketched out a pretty rigorous schedule, starting back in March when schools closed. And the kids have been just on a regular rhythm, still learning, but having a lot more fun with a lot more flexibility. And so, I think the family, despite the weirdness, has been thriving through this COVID season.
Sorry, I have some background noise, so I muted myself. But yeah, I'm sure your kids are finding some benefit, sleeping in a little bit and things like that. Yeah, through all of this. But thank you for sharing all that, Danny. You mentioned that it's been such a different experience over the last few months. And again, reading in the column, and of course, just imagining that your entire team has had to focus on, I'm sure you do many things every single day, and there are other health concerns, but with this coronavirus, just sort of taking over our lives, how have you been able to balance all of the other responsibilities along with focusing on a virus that is we're being affected by just like every other county and city in the world?
I don't know that there's been much balance, Yvonne. This is basically front and center for almost everybody in the department. There are certain things that are kind of direct services, like our WIC program, for example, the Women and Children program that provides nutritional supplements to low-income women. So that has continued. We have really scaled down our clinical services. We do like some of what the health department does is provide direct care for certain populations, for refugees, for folks seeking out immunizations. We run a family planning clinic, but all of those services have really been scaled down. And I would say, between Henrico and Richmond, we were about 240 people. We've added 100 staff in the last 3 months. When you think about what we've had to scale up to make sure we have enough people to do case investigations and to follow up and do contact tracing. So it has just been an enormous undertaking over the last 4 months or so as we've built out. I feel like we've had to build a bunch of new business lines because while infectious disease, communicable disease control is a core part of what departments always do, we have 4 epidemiologists between Henrico and Richmond. And what we've had to do is kind of pivot and train a bunch of nurses to be able to go into facilities like a nursing home or assisted living facility to make recommendations around infection prevention. And then we had to bring on and rapidly train, 50 to 60 contact tracers to engage in that work. And so it really has been all hands on deck, and some of that has been really exciting. Like, there's a part of me that just thrives in the challenge of that and the chaos of that, but it has also been really exhausting for the staff who are just stretched in every way you can imagine.
Right. Well, I just want to say on behalf of Innsbruck, thank you, because with all of that happening, for you to be on point and your team to be, I'm sure, working tremendous hours. We appreciate that response. There are many topics that come up with this novel coronavirus, but I just want to unwrap as many as we can get to today and talk about other things as well. But again, it sort of sucks the air out of the room and makes you focus on it. One of the things that seems to be a big topic for most conversations is, well, this is just like the flu, I've heard people say. So how is this virus different from other viruses?
Well, I think public health is largely to blame for some of the confusion around that. When this was initially circulating and discovered in China back in January, both the World Health Organization and the CDC, our initial messaging was, let's not get overly concerned. This isn't any worse than the flu. We're in the midst of a flu season. Let's pay attention to what's in front of us. And, pretty quickly from January to February, we recognized that there were significant differences, both in the contagiousness of COVID, but also in the fatality rate of COVID. And so while those numbers kind of shifted a little bit as we have a better picture, we're doing testing, we understand that there are broader range of symptoms with COVID, fatality rates are still, anywhere from 20 to 50 times higher from COVID as they are to flu. And maybe one that's particularly true in kids, but really it extends to the age span. Sorry. Let me rephrase that. It is not true in kids. Kids are much more resistant to COVID. It is much more true in the adult population. So that's another interesting twist between COVID and flu that we can talk about a little later on. Yeah, I mean, I think, at the beginning we were like, it's not any worse. We realized quickly that, oh, actually, it is way worse. It's both more contagious and more fatal. And so just to put that in perspective, on a typical season in the U.S., somewhere between 20 and then on a really bad year, about 60,000 people in this country die to the flu because of the flu over the entirety of a flu season, typically a 6-month period from October to March. And in the 5 months that we have been facing COVID here, we've had 135, 137,000 deaths now. So, the death toll.
Could you repeat that number? Danny, we're having trouble with your audio a little bit. I don't want anybody to miss that. What was the number you just gave for how many people have died since January?
Yeah, from COVID, the latest numbers from today are 137,420 deaths here in the United States.
Wow.
So, a significantly larger proportion of our population, both being impacted by COVID and losing their lives to COVID. Should I switch my internet connector? Is it coming in a lot?
This is definitely not my forte. I don't know what, I know my marketing director was looking for what he could do to help, but it's just, you're breaking up here and there.
I think what might be helpful, Danny, is if you sit back from your microphone a little bit. I don't know how close you are to it, but it seemed to be jumbled when you got a little bit closer, but we can try that and see if that helps.
Yeah, Steven, just let me know, and I've got a hotspot I can switch to if we think it's a bandwidth issue. But
okay, all right. Well, thank you so much, Danny. I wanted people to hear that perspective because, as I said, there are many points of concern regarding COVID, but one of the things that kind of bothers me in a way that I feel out of control is when you hear differing opinions and you're not sure exactly which one to believe, whether you hear it or you read it. So obviously the focus here is wearing a mask and diligently washing our hands. And I made a comment the other day, and I don't mean to be flippant, but I do feel as though, history will not be particularly kind to us if it's discovered that not the only reason, but one of the major reasons that so many people became ill and died is because we refused to wear masks and wash our hands. That's kind of, anyway, but can we just talk about how much prevention that does provide in terms of, especially the wearing the mask part?
Yeah, and again, I'll point to kind of the national public health messaging that has created confusion here. You'll remember in February and maybe even some of March, when this was just told in the United States, our initial messaging was we need to preserve masks for who need them most, so healthcare workers and those in kind of higher risk situations, first responders. And that otherwise masks really don't help you that much. And, I think that we clearly missed the boat on that. Other countries that have much higher adherence to masks, even during general flu season, particularly China and Korea, there was a lot of marketing and, sort of messaging coming out of Europe talking about the value of mask wearing. And I think we in America just, that hadn't been part of our practice, and it's not, so there was a lot of resistance at the national level to adopting that practice of mask wearing. And I think what we've seen and what just study after study shows is that mask wearing makes a huge difference in the transmission of COVID, which is primarily transmitted through respiratory particles. All right, let me switch over and see if this will help.
Okay. Hopefully it does. Yeah, looks a little more stable. We have a question. Actually, we were going to get to this a little bit later, but I don't want to miss it, and it might get lost in the chat. Pat O'Bannon, who is on the Henrico Board of Supervisors and the Airport Commission, is with us. So happy to see you, Pat, by the way. She's asking, does taking zinc or vitamin B12. Do those types of vitamins and supplements help?
Yeah, there have not been any specific studies as they relate to COVID prevention for things like zinc and B12 and vitamin C or vitamin D. But I think logic would certainly compel us that those things have been shown to help boost immune response in general. And, I think there's a spectrum, right? There's some things that maybe are a little bit more not experimental, but less proven, things like elderberry and but that have a large following. So I guess what I would say is that anything that there's a decent evidence base around in terms of vitamins that increase your immune response, your immune protection, and I would certainly put zinc and B12 and vitamin C and even to some degree vitamin D. There's a whole nother host of literature around vitamin D, but those will help. I mean, those will help boost your immune system. They'll help, protect you from severity of infection. Again, there have not been specific data showing the impact of specific vitamins on COVID outcomes per se.
Okay, yeah. Well, thank you, Pat, for the question. And moving into, again, we were talking about mask and hand washing. So behavioral health, I looked this up when I was preparing, and it's defined as the connection between behaviors and the health and well-being of the body, mind, and spirit. So, according to you and all the amazing health professionals who are trying to get the information out there about how we can protect ourselves and how we can possibly stop this thing in its tracks, that is something that we can control. In fact, the governor, and this is not a political statement, I'm just, he did an announcement a couple of days ago when he said that this is something we actually can control in terms of the rapid spread of this disease. But there is a distinct polarization of attitudes and beliefs that have resulted in different behavioral responses to COVID-19. And this is maybe coming a little bit out of what you focus on every day, but is there a way for us to get on the same page? And I know what you're saying in terms of where it all started, but now here we are, and we're seeing states that are reopening and they're having disastrous results with just sort of, opening up the gates entirely. And we got to get business going again. We're starving for events in Innsbruck, and we're starving as people just to reconnect. So how do we get on the same page with all this and protect ourselves, from just certain doom in terms of business and health?
Well, there is certainly just a deep divide that exists right now. And it's not even like a clear one side versus another. I just think when you think about first sort of the American ethos of individualism, of freedom, of my rights, I think that there is this sort of knee-jerk response, regardless of what the data says, but that somehow a requirement to wear a mask is infringing on your rights. And I think in countries that in Europe and Asia that have more communal sensibilities, things that protect others, things that protect your neighbors are just much more common. It's more the way that people think. And so I think that, from the beginnings of America, that's not necessarily what we were built around or what we default to. And so that's a basic challenge. And so in really practical ways with COVID, things like a recommendation to wear masks or contact tracing, are met with a lot of distrust, and distrust for different reasons. I mean, for some segment of the population, it's distrust about, first you're telling me that we don't need to wear masks, and now you're telling me that we are. I don't want to wear masks. You're telling me that wearing a mask protects others, but it doesn't protect myself. I don't want to do that. But then you've also got the distrust among, large minority communities, African Americans or Hispanic communities have different reasons to distrust government guidelines. The fact that we have, for decades and centuries, had mass experimentation, mass mistreatment of the African American community through healthcare and through government. And so there's a skepticism that public health guidelines are met with. For our Hispanic community, much of which in this region is undocumented, trying to get messaging across and trying to engage residents as a governmental entity is met with a lot of distrust. So there's so many different layers of why there's not a unified national voice on this. There's not a credible, I think the credibility of some of our national institutions has really been called into question. And so there are just so many differing perspectives. And, to answer your question, how do we get on the same page? As a physician, as a scientist, like my answer would be, we've got to look to the data, but not everyone buys that. And so I don't know what to do when we're not really willing to look to anything as a basic truth or a consistent truth. And so I do think we have got to change our messaging and change our approach with different audiences and kind of appeal to different sensibilities when we make our recommendations.
Yeah, and we were going to get to this later, but you provided a great segue in terms of the distrust of government. I heard in the headlines yesterday, I think it was yesterday, that hospitals have now been ordered to bypass the Centers for Disease Control and Prevention and send all their information to a central database in Washington. So I was listening to, a report about this. Of course, it depends on where you listen to it, but this particular report was, interviewing some people and saying, is this a political move or is this really needed? And the guy they were interviewing, unfortunately, I don't remember his name, but he was previously with the CDC. And he said, in one way, I get it. There have been many complaints about the slowness of getting, actual information out there to the public when it goes to the CDC. On the other hand, some people think it was political. So, here's an example of already, it was literally in the headlines, and distrust and different messaging was coming out right away. Regarding the bypassing. I don't even get that. Like I've always, the CDC, they're the folks who, and NIH, they know what's going on scientifically and in terms of data, and we're going to take some kind of, beltway around them. I don't understand.
Yeah, but I think it's a perfect example of the environment that we're in today, where science and data are not necessarily what people are looking to, or they just don't trust it because they feel like there's some other agenda or some other motive underlying that. And I think the way that politics evolved in our country has given people understandable reason to believe that. And yeah, I'm with you. The CDC has been the most trusted source of guidance and information for decades. Sure, there have clearly been missteps. I think at the beginning of our national COVID response, when the U.S. had the option to purchase the testing that Germany had developed versus trying to create our own, we decided to create our own. And it set us back more than a month in terms of having adequate access to testing. And so there have been other things along the way that have slowed our national response and places where maybe the CDC has not done the best job, but they have always been the national repository of data. And so I don't know what we accomplished by the headline that came out yesterday. In one hand, it seems like the White House is trying to figure out how we make sure that we're seeing the real numbers, and hopefully there will be transparency with that. I'm not 100% certain about that, but I think what will likely happen is that the CDC will continue to collect the data and report it as they have been. I don't know what will happen with the direct reporting, and frankly, it just creates another area of confusion in terms of data collection and reporting, and another layer of stuff that healthcare systems have to do. That's just going to be frustrating. So it's a pretty unfortunate development, in my opinion.
Yeah, well, let's bring it back to our area in terms of our region. One of the things that is really grabbing everyone's attention right now, because we're almost into August, is school.
Mhm.
And what are we going to do about kids going back to school? From what I understand, this is going to be sort of a locally sourced decision-making process. But in my mind, if I were a teacher and I'm going into a classroom with kids, I don't know where they went all summer. I don't know who's sick in their home. They don't know if I'm sick. Plus, just the nature of kids, they like to touch and play with each other, and and they're grabbing stuff and they're fun and they want to hug. I haven't seen you all summer, and all that sort of natural stuff, which is unfortunately runs counter to what we need to do for COVID, in response to COVID. So what do you see on the horizon for schools and education until we get a vaccine?
So I think you're definitely right that the decision has been pushed to localities. And in fact, when the formal guidance came from the Department of Education, Department of Health a week ago, Monday, it said, here's a guideline that we would like you to consider, but ultimately each individual school board has to make the decision. Now, that was not the case back in March when we were watching rates increase in Virginia and the governor made a clear central decision to close schools. And that could happen again. We have been on a small uptick of disease throughout the state of Virginia. That has been particularly true in the Eastern region and Ambrose area in Virginia Beach, where they have sharp increases in the number of cases that they're seeing and their percent positivity. So it's not just a function of more testing. Central Virginia has been much more steady. We've really plateaued. I've seen a little bit of an uptick in daily cases in Richmond. So last week we were averaging somewhere between 15 and 17 new cases a day. And this week that's more like 25. So a little bit of an uptick that certainly we need to keep an eye on. Henrico has been less affected. We did have one significant spike of new cases that correlated with the outbreak in the jail, but otherwise, has been pretty steady. So it's hard to know, and I think that any uptick in disease we're seeing right now certainly correlate to the fact that we started phase 3 back on July 1st, right? So we went on July 1st, we went to a new phase where restaurants had fewer restrictions, where non-essential retail was completely opened up. A lot of the restrictions were dropped there, where you could now go, from gatherings of up to 250 and then even up to 1,000 in certain circumstances. So the fact that there was an opening up on phase 3 and then heading into a July 4th weekend that I think probably fostered a lot of gatherings, I fully expected that we would see a small bump in cases approximately a week after that, just because that's the typical 5 to 7 day incubation time, and then the lag for somebody to develop symptoms and go get tested. So I'm not surprised. Now, what will be interesting is what happens over the next couple of weeks. Do we just see a little bump and then another plateau and then a decrease, or do we see sustained increases in rates like some of our neighboring states have seen over the last few weeks? And if it's the latter, then I would not be surprised if the governor made a more unilateral decision about schools in the Commonwealth. So long intro, let's get to schools. It's a huge focus of my time and energy right now is trying to be an advisor to both Henrico County and Richmond in their school decision making. As some of you may know, the city school board voted to go all virtual for the first semester. So from September to the middle of January, all instruction will be virtual. Henrico will make that decision, I think, on July 23rd. I've spent a good chunk of my week in various focus groups with different groups of teachers, with bus drivers, with Henrico school leadership. And here's, kind of the public health perspective on this, that as we look at the data around school outbreaks cases in children and the contribution that schools being open makes to community spread. Remember, we don't have a lot of data to look at in the United States because most schools across the country have been closed for the last few months. But in many countries, schools either stayed open throughout the outbreak or opened up as things subsided. And so we do have a growing body of evidence, largely international evidence. But in the US, we have a lot of data around your daycare populations because, from the beginning of the pandemic, daycares have continued to take care of kids for essential workers, for healthcare workers. And so we have a lot to point to there. And I'll say that the summary of that data shows that kids are less likely to get COVID. They are less likely to transmit COVID to other kids and to adults. And they are extremely unlikely to get any severe disease from COVID. We have very few hospitalizations and even fewer deaths in the 0 to 10 population in particular. And so, I think about a week and a half ago, the American Academy of Pediatrics came out with a statement that said, there are clear downsides to not having to school, and we need to consider those as we're making decisions. And the AAP was really pushing for kids to return to school, because the downside when kids aren't engaged in school is that they suffer from a whole host of other negative outcomes of mental and behavioral health outcomes. There was a large scale study in the United Kingdom that showed that kids 10 and under who were not in school had statistically significant increases in anxiety and depression. We are concerned about the incidence of child abuse when you don't have other adults who are engaging with the family outside of a potentially abusive situation, because it's people in schools that primarily identify patterns of abuse and neglect and report those to social services. And so when that interaction isn't happening, there's concerns that, because child abuse reports are clearly down during this COVID era. And we have spot reports from emergency rooms around the country, VCU being one of them, that are saying we're seeing fewer patients with complaints of child abuse, but the severity when they come to the emergency room it's more severe. We're seeing more severe injuries in young kids. So it is a really complicated decision, because while I think there is a clear body of evidence that kids are not going to suffer the impacts of COVID, and kids are not going to likely transmit COVID at high rates, you've still got adults in those school buildings. You've got teachers and other administrators, some portion of whom are going to be at higher risk to COVID because of their underlying health status. And so it's not a decision that can solely be made around kids. And that's why I think every school system across the Commonwealth is really wrestling with this. And so they're trying to work through, with the in-person option on one end and a full virtual option on the other end, are there different ways that we could hybridize? Can we stagger the kids who come? Should we have one group come 1 week and another group come the second week, so that you can actually decrease the total number of kids who are in any one place at any one time, and try to do school with appropriate distancing and mask wearing and screening? So, where are we with that? I just think that no matter what, this year is not going to be as good as any other scenario, right? Like, there are going to be losses in terms of educational outcomes and social outcomes, and we need to recognize that and figure out how do we do our best to strike the balance of minimizing a situation that's going to contribute to more spread of COVID, but also maximizing the educational gain and social and emotional development of kids through school interactions. And so we'll see what happens.
Yeah. So when you say children are less of a less concern regarding, it being transmitted and even catching it, did you say 0 to 10 years old? Is that sort of the? Okay.
0 to 10. Yeah. A lot of the studies in adolescents show that they actually transmit COVID pretty closely aligned to adults. And the hypothesis is that the older you are, the more circulating receptors you have in your body for the COVID virus. And so the more viral particles that latch onto those receptors, the more of a response you have. And so you are more symptomatic and you shed more virus, therefore making yourself more contagious. What we see in young kids is that you have the majority of young kids have really mild disease or asymptomatic disease, and therefore they don't spread it as much.
Right. We have some questions that have popped up. I'm going to let Stephen take over to guide the questions. I think we had one before Jonathan, maybe, and then we have questions.
So the first question we had, let's see if I can pull it back up. What will the fall or winter look like if we are facing potential outbreaks of both the more common flu and COVID-19? That's the first question.
I think much of what public health leaders around the world are anticipating is that we will have this layering effect of our normal flu season, which normally sees more people hospitalized for respiratory illness during those winter months, and then the added burden of COVID hospitalization as well. And so, I think I'm pretty concerned about what that means for our hospital capacity. And maybe let me just take a quick sidestep to talk about, the metrics that matter and the what increases need. Back to that question. I think there understandably is a lot of concern when we see increasing rates of COVID in a community. I do think that increasing cases by themselves, while they can be a marker for things to come, are not in and of itself a major concern. And the reason I say that is because even still, most people who get COVID have pretty self-limited disease. And so more cases just means that, more people are getting it. Now, the thing that we really need to pay attention to is, does that mean more people are getting severe disease and requiring hospitalization? And ultimately, are more people dying of COVID? And so we have not seen hospital numbers really ratchet up in terms of COVID hospitalizations. They've stayed pretty flat. A couple of bumps here and there, but by and large, we have not seen that yet. And then we've definitely continued to see low rates of death to the disease. And I think that's a couple reasons for that. One, that death is a lagging indicator, as you no doubt have heard, that we typically don't see deaths rise until weeks after, 3 to 4 weeks after you see the case count rise. But also, I think that our treatment is getting better. Knowing what to do with a severely ill person in the hospital, recognizing the symptoms earlier and getting them to acute care earlier. We have one antiviral medication, remdesivir, that has shown some improvement of hospital outcomes. And then about 3 weeks ago, there was a new article in the British Medical Journal that talked about Decadron or dexamethasone, a very common steroid, improving hospitalization. So I think things are getting better in terms of how the acute interventions are playing out in the hospital setting. And I think the elderly, who are clearly the most susceptible and the most likely to die if they get COVID, that 85 and up population in particular, are avoiding contact and being cloistered even more during this season. So all that to say that, while looking at the number of cases is helpful for us to know how much potential circulating disease is going on in our community, it's not necessary, like in and of itself, it is not a really worrisome thing. I really am more worried if we start to see sustained increases in hospitalization and death. Yeah, I mean, I think some of the modeling that's being done nationally and here in Virginia shows that we are heading towards a peak of disease in the fall and early winter. And And so it will push hospitals to go back to some of the surge planning that they were doing early on in this pandemic. We were having regular conversations with our 3 health systems about overflow options. VCU was considering turning one of their dorms into an overflow hospital. For a while, we were doing active planning around the convention center downtown as a field hospital. What happened is, in the midst of all of that planning, our case counts and our hospitalization rates were continuing to decline. And so we were able to step back. But the good news is that all of those plans are clearly in place. And if we got to a place where we needed to relook at hospital surge, we would be able to pick that up more quickly than we were the first time around.
Awesome. That was an awesome response. It was perfect. A lot of good information. That's why we brought you here. We want the good stuff. The other question we have is from Jonathan Hewitson. He asks, are there any specific local or national medical or news sources that you like to stay in tune with, or you have found to be accurate, rather than listening to a news station that might have more on either side, more of a political agenda? What do you like to listen to for accurate information?
Yeah, I'll be honest. I do both. I don't think there's a lot of great media outlets that do a great job of really walking the lines. So on one side, CNN and NPR, and on the other side, Fox News. And so I really try to see what the headlines are and how they're framed in from different media outlets. I mean, I think for as credible information, the CDC is generally where I go. The state does a good job of culling all of the updated information on a daily basis from the CDC and sending that out to the health departments. And so I try to just stay on top of what's emerging. I think, so no, I don't have a great answer of who's providing really good neutral reporting on this. But I do find it helpful to look at the spectrum and get a sense of where different people are at.
So it's kind of like shopping, you want to make sure you do some comparative shopping before you buy anything. Yeah. Well, I think that's a great answer, because it does give you a more balanced look when you go to different sources. So I wanted to ask you about this graph I saw, and anyone who also has a question, please jump right in, and Stephen will be monitoring that. But I saw a graph, and it was showing different scenarios. The first graph was a person wearing a mask who has COVID, and a person who is, if I'm getting this right, wearing a mask that doesn't have COVID. Versus someone wearing a mask who has COVID, and someone who isn't wearing a mask, who doesn't have it. And you know where I'm going with this. And then someone who doesn't have COVID, but who's wearing a mask, and someone over here who does have COVID wearing a mask. How do those compare to one another? And, if you could just speak to those different scenarios. I'm not even sure if I brought that up the right way.
I know exactly the diagram you're talking about. It's got two people facing each other.
Yes.
And in one case, there's a person who's infected with COVID who's not wearing a mask, and there's a person who's also not wearing a mask. And in that scenario, you've got an infected person and an uninfected person. And I don't know how true these numbers are, but the number is that there's a 70% rate of transmission from one person to the other. Now, and then there's a second line where you've got that same person who is the COVID affected person is wearing a mask, and the non-person is not wearing a mask. And that drops from 70 to 5%. And then the same scenario, except both people are wearing a mask, and the transmission drops to 1.5%. So again, I don't know where the data comes from. I don't know, how they came up with that. But the concept is definitely true, which is that the reason we wear these face coverings, these cloth masks, is because they actually block, they serve as a, a barrier to the respiratory droplets. What we know about COVID is that 90 to 95% of disease transmission happens through respiratory droplets. So when I talk, when I cough, when I sing, when I sneeze, I'm putting respiratory droplets into the air constantly. Sometimes you have to see them in a really vigorous talker. You'll see the spittle coming out of somebody's mouth, you know? But at any time, there are, invisible to the eye, lots of respiratory droplets that are coming to the air. And those respiratory droplets are on a spectrum of size. So the larger droplets are going to fall to the ground somewhat quickly. Smaller droplets might actually suspend in the air enough for somebody else to inhale them and become adults. So this idea of how do we minimize the number of respiratory droplets that are coming from your mouth, potentially hanging out in the air and having somebody else breathe them in, is what we're after with wearing cloth face coverings. So when you wear a mask over your nose and your mouth, you are blocking the majority of respiratory droplets from being suspended in the air. Now, and so the goal there is to just minimize how many droplets you put out there.
Okay. Yeah. And so we have a question actually we're going to get to in just a moment. Thank you, Deborah. But I wanted to talk about inside versus outside, because you talked about the larger droplets. And again, I watch a lot of, all these videos and various information that's out there. And there was this graphic showing people socially distanced inside, and they talked about the large droplets and the micro droplets. It was actually a study that was going on, I think in China, about micro droplets. But what about outside? Like, how important is it when you're outside? If I'm standing 6 feet from another person, am I still at risk without a mask? And I'm really being selfish here because, we have people coming to do the lawn and another person who's going to do this work on the house and that. And a lot of them do not have a mask. And so sometimes I'll say to them, where's your mask? And or I'll just wear mine, but I'm wondering, then I think to myself, am I going overboard?
So
outside?
One of the clear things that we have learned about COVID is that inside exposure is much more significant than outside exposure. Your risk to contract COVID in indoor spaces is greater than 20 times as great as than if the same group of people were.
Three times, you said?
20 times.
Oh.
So it's a very significant difference. And, whenever people ask me about gatherings, my first answer is always outside is better than inside. As much as you can push things to the outdoors, that has a really significant impact on transmission. So, when people are outside and they're out and about on their own, there really is not a reason to wear masks, because those respiratory droplets really, especially outside, both the impact of, airflow of respiratory droplets not concentrating into a defined airspace, the UV effect of sunlight. I think there really is a minimal risk of exposure when you're outside. Now, if you're going to be outside and within 3 to 6 feet of somebody, then I would recommend wearing masks in those scenarios, because while your risk is lower, it's still present if you are, talking at a close distance with people. Right. So, I would say the guidance is, if you can stay outside and stay more than 6 feet, I don't really think you need to wear a mask. And I would say that some of what, if we had a case study around that, it would be the protests that we've seen here in Richmond over the last month. And actually all over the country. We fully expected that gatherings of thousands of people would lead to a spike in disease, and we did not see that. In Minnesota, they actually did kind of a spot study where they were testing people that came directly from protests, and they tested over 2,000 people and had a positivity rate of less than 2% of those individuals who had been protesting who tested positive for COVID. So I do think that there is something about being outside that really lowers your risk. If you are indoors, yeah, I mean, I think wearing a mask, the guidance is to wear a mask anytime you're congregating indoors. Obviously, if you can keep it, I've been to meetings where people are 10 feet or more from each other and we're not there for extended periods of time. That is safe. But I think indoors, both the possibility of your respiratory droplets concentrating in space and the time that people are exposed, right? Because your risk of infection is based on exposure and time. You're increasing your risk by being with a small or a group of people in a small defined space.
Got it. Thank you so much. Deborah, we'll start with you. We actually have two questions. And Deborah's saying, I'm concerned about going back into the workplace and using a public restroom. What are your views on prevention that we should take going back into the workplace?
So there are two primary ways that bathrooms can fuel transmission. One of the things that we've learned about it is that you can shed there's high rate of viral shedding in feces. So if somebody goes to a bathroom, and there's some speculation, and I don't know how good the science is around this, but one of the scenarios that people have said may actually lead to the aerosolization is if somebody goes, number two, and then they flush, the flush itself will actually express viral particles into the air, and then you can inhale those. So I know that's super gross, but some of the things that people say is just close the toilet lid before you flush in a public space. But the main way that bathroom presents risk is just through high contact surfaces. So the door handle going into the bathroom, the door handle of the stall, the faucet. Now, on the reassuring side, it turns out that what's called fomite spread, a fomite is a small particle that a viral particles can be transmitted on. Contact spread is another way we talk about it. That only contributes to probably 5 to 10% of the way that somebody gets the disease. Like I said earlier, the vast majority of COVID is transmitted through respiratory droplets. So contact is a lower risk of transmission. And so what I would recommend for workplaces is that you have regular wiping down of those high contact surfaces, that you have twice a day somebody going through and wiping down the door handles and wiping down the faucets. But there are also practices that I, as a public health doc, have been doing for years, but now have become more normal, to not touch the faucet with your hand. A lot of places have now added kind of hooks that you don't have to touch the door with your hand. You can either open it with your foot or with your arm. Or I always use a paper towel when I'm opening the door when I'm leaving the restroom. So I think many of those practices to minimize your touch of those high contact surfaces would suffice.
Yeah, I've been using the hem of my shirt or my sleeve to open doors for I don't know how long, and everybody always made fun of me, and I'm finally vindicated. All right, let's get to another good question. Pat O'Bannon says, I just went to the dentist today, and he has installed a UV system in his HVAC air handling unit. Is that needed in public buildings?
I would have to do a little more research on that, Pat. I mean, UV is clearly an effective disinfectant. And so, for example, in facilities where we use N95 respirators, so the hospital grade fitted masks, we have, the state's been able to set up a system where those masks can be treated with UV light. And so if let's say you're a nursing home operator, you've got 150 staff, they all use their N95 masks for a day. Those can be shipped down to Chesterfield Fairgrounds. They zap it in this UV machine, they're disinfected, and they can reuse those N95 masks. And that extends the life of your N95 mask. You can do that 5 or 6 times before they stay. So UVs are clearly an effective way to disinfect. What I am not as sure about is the UV through an HVAC system an effective way? HEPA filters are, But I would just, I'd need to look more into that particular setup and see if it's time tested.
Thank you. And thank you, Pat. You made me think of another question. So I have taken on this little task of everybody in my family, wearing your mask. Then you give them to me at the end of the day, and I wash them in this solution that, according to the label, kills everything, just every germ out there. And then I also add just regular dish detergent and very, very hot water. And I let them sit for a while, and then I scrub them really well. And then I let them air dry. Is that an effective way of keeping your, because I do want to reuse the ones that have that ability to be reused. The ones that I put the can't remember what that filter is called, some kind of filter inside of.
Yeah, I would say, so the data about COVID living on surfaces is that on fabric surfaces or cardboard surfaces, the virus can't really live for more than 24 hours. There has been no documented transmissions through fabric sharing. In an ideal situation with the right temperature, with the right airflow, they've been able to isolate live virus up to 3 days on glass or metal surfaces. So what does that mean? I mean, I think that, washing cloth masks is less about like the fear of transmitting the virus and more about just general hygiene. And so, because at the end of a day of wearing a mask, it just gets kind of a little bit gross. And so I typically just throw mine in the general washing machine. One of the things about COVID that maybe is a little bit misunderstood is that it's not a very hardy virus. It's very easily killed through a wash or through the use of any generic disinfectant. So back to the scenario we were talking about earlier with bathrooms, we early on in this pandemic, we had identified a case, we would shut down an office and order up a deep clean, and then people would have to wait a certain 24 to 48 hours before they came back to the building. That's really not necessary at this point. I mean, I think we, again, both because of the low rate of transmission and the fact that this disease is very easily killed, I think just really standard wiping down of surfaces with a disinfectant is all we really need to do.
Okay, well, we're going to start to wrap up. I don't want to not have enough time for general questions. We do have a question from, and you answered it on the medications. Thank you very much, Danny. So, in Innsbruck, we do events. That's what we do. So we're hosting a drive-in tonight, and that was our way of responding to the concern for large gatherings. Everybody's in their own car, and we're going to have a drive-in. But the governor is still saying for outdoor events, no more than 1,000 people at outdoor events. If one can achieve, one thing I don't want to do is I don't want Innsbruck to be the one place that took a risk. That's not part of my plan. I think that we're pretty good with a drive-in, any kind of drive-in situation where you can stay with your family and friends. But is there really a safe way of having 1,000 people in a space as long as you keep folks at least 6 to 10 feet apart? Is that even a thing?
Yeah, I mean, I think part of why the guidance changed in phase 3 to allow that is that there are scenarios where it presents low to zero risk. And so what you described, at least what I'm picturing, is that you've got a field where people can drive, they're with their family and friends in their car that they came with, they're not interacting with the next car over, or there's adequate spacing. That scenario feels totally safe to me.
Okay. All right, thank you. So Deborah Willis says, there seems to be a backlog with getting results of testing. It is very stressful for people to wait 5 to 7 days for results. Can that be improved? How important?
Yeah.
And then she has a second question. How important is it to give plasma locally?
So I'll talk about the testing first. This has been extremely frustrating. We'd gotten to a really good place, both in terms of testing accessibility. I think that's true. I mean, you can go to most urgent care centers, now retail drugstores, so CVS and Walgreens, and Rite is coming on as well. So testing availability is really good. What we've seen in the last now week and a half, really because of just the demand that we're seeing because of surging case counts in the South and Southwest, is that labs are going out to commercial, these large commercial labs, or even local commercial labs, like they're just being overwhelmed. And so even if you can go get a test, you're not seeing a result for a week or longer, and that is changes our response, right? When we're trying to contain disease in a nursing home or a workplace outbreak, to not have results for a week is just, I mean, it's useless to us. So it's a huge problem. It's what we were facing at the beginning of this, and I think it actually contributed to a lot of spread that could have been avoided if we had better turnaround times. I think it is one of the examples of just a failure of centralized leadership around our state's responses. We just have not been able to solve the problem of testing volume and turnaround time. So it is really problematic. How can it be improved? I mean, the way that it got improved in its first phase is that we had the introduction of a lot of new labs. So we had local labs in the region that stepped up and added the capacity to do this, but they were still to some degree hamstrung by this national supply of things like the reagents that are needed for the machines to run the tests. So I don't know what is happening at state and national level right now, just in the last week, because it's a fairly new trend that we're seeing over the last, I would say 7 to 9 days. But I do hope with you that it can be fixed, because it's very problematic. Certainly to individuals waiting on their own results and trying to figure out do they need to continue to be quarantined, and then also in the group outbreak investigation scenarios. And then another question about giving plasma locally. Yeah, if you have had it, then there is ongoing research being done about the value of plasma that has circulating antibodies, and so that's actually used in a lot of medical centers across the country. The jury is still out on whether it makes a big difference or not. I do think because we're all trying to learn what works and what doesn't, if you have been exposed to COVID and can give your plasma, it would definitely help a larger body of knowledge to do that. And I'll answer this last question on vaccines. So there are, companies all over the world, and I think 13 in particular that are continuing to make good progress on vaccine development. There was a really encouraging report. I think Moderna is one of those companies that just started its first small-scale trial in humans and found that their vaccine did produce a robust antibody response. So I do think that there's a lot of optimism should be had around vaccine development. Right now, the national and state infrastructure is preparing for vaccine distribution that could start as early as the end of 2020, December 2020, and that would really be prioritized for very high-risk populations. So our elderly, those who live in congregate care facilities or work in congregate care facilities, and then hospital workers. And then the second round of that would likely happen in the spring of 2021, and that's it takes a while to both go through the safety testing, but then also to scale up production and distribution. And with something like this, it's just going to be tens of millions of people who are lining up for vaccine. So that timeline is what the federal government is reporting. It sounds a little bit aggressive to me. I think we're probably more like 4 to 6 months out from widespread distribution of, sorry, not 4 to 6 months. I think it's more like April to June of 21 that we'll see widespread distribution of vaccine. But we are preparing for the scenario that we have vaccine ready to go at the end of 2021.
Wow, that is really crazy to think about. You know, I guess in my mind, I'm thinking, oh, we'll have the vaccine in January and everybody will be good to go. Doesn't quite work like that, does it?
Well, I hope. I mean, I will say what's unique about the pursuit of a COVID vaccine is that there's no time in history that we've had such focused time, attention, money to a solution that is, that the entire globe is clamoring for. The fastest historically that we've been able to develop a vaccine was 4 years for the measles vaccine. But again, I mean, there's this, it's on the degree of attention and focus on developing a COVID vaccine is unprecedented. And some of the early returns look good. And I think it's possible certainly that we'll have something to distribute by the end of the year.
All right. Pat O'Bannon we'll take this as the last question. And
I think
thank
Peter
you, Pat.
Larson may have unmuted himself to ask a question a little earlier as well, but
okay.
Yeah, I'm okay. I'm okay. I just unmuted myself by accident.
Oh, okay. All right.
I just don't like being muted. You know what I'm saying?
No worries, Peter. Pat is saying here, Henrico County sends out a daily report about the COVID-19 virus activities with graphs and statistics. And Henrico, I am checking now about the HOW. Oh, I'm sorry. I thought that was an organization. How anyone can receive the report. It's WHO. And if they want it. So that's good information, Pat. Thank you. Is there a site that people should check in on, Danny, in terms of getting statistics?
Yeah, I mean, the state website actually does a great job of updating information on a daily basis, and it's really interactive. So you can, and I don't know, can't share my screen, can I? No. Okay. Stephen, if you want to let me, I can show you where it is, and people can just at least get a flavor of what they can. If not, I can just put the website. What is that?
Yeah, I think you should be able to do it now.
Okay, let's try this. All right. Find it. Okay.
Is that your calendar, Danny?
Sorry.
I think I had a heart attack. Looking at your calendar.
Yes, my life is pretty insane these days. Okay, so this is let me actually just show everybody how to get there because it's pretty easy. So the VDH, if you just Google VDH or VDH COVID, you'll come to the VDH website. You click on COVID-19 data, and then this daily dashboard. So the daily dashboard is organized first at the state level. Actually, let me minimize this so you can see this. So you can see, and this is updated every morning. So the total number of cases in the state, total number of hospitalizations, and total number of deaths. And then when you hover over different areas, you can actually see it break down by locality. So for Henrico, you can then see the cases, hospitalizations, and deaths and rates for Henrico's population. You then can come down and see the epidemiologic curve for the state. But then all of this you can do by locality as well. So if I want to look at the race breakdown or the gender breakdown of cases, hospitalizations, and deaths for Henrico, I would click on that demographics tab, and then I would search by locality by Henrico. And then what it updates all of the information for Henrico. So now you can see what the age distribution of deaths is. You can see the racial distribution you can do it for cases. You click cases, hospitalizations, or deaths here. So let's do that for deaths. and then you can see the breakdown. So, the vast majority of our deaths, and this is true for everywhere, but I think it's particularly true for Henrico because we have such a high concentration of assisted living and nursing homes in the county. But you see that it's our 70 and up that really the most of our cases are. And then you can see the racial breakdown. So in the county, 44% of our deaths are Black and 50% of our deaths are white. So there's a ton of information here, a lot of different ways. And then the last thing I'll show you is this testing tab. This again is updated on a daily basis. And if we search for Henrico, so here, so this is our daily case count and our daily positivity rate. And so what you see here is that over the last week, little over a week. So over the last week, we've had a slight uptick in percent positivity from 4.7% to 6%. And so you're seeing a little bit more positivity. These dark blue lines are the actual number of tests that we do every day. And so you see that we have maintained a fairly high level of testing. So anyway, I'll stop there, but I just want everybody to know that this exists and people can kind of sort through it and parse through it for different, all the localities in the state.
That is fantastic. I did not know you could get all that information. Well, Danny, I just want to thank you so much. What an honor to have you join us. And hopefully we'll be able to do this again next year when we can meet in person and we can talk about the returning to some semblance of life as we knew it, which actually I had as a question. I don't know if this is a fair question, but is there some moment that we'll be able to go back to life as we knew it, or are our lives changed forever? Are we going to be more vigilant? We're going to have to be more vigilant going forward.
Well, I mean, I think there are pieces of life that will get back to normal. I mean, I think when a vaccine is introduced and an effective vaccine is introduced, I think when we have more clarity about your immune response, like once you've been exposed to COVID and you have antibodies, just how long does that protect you for? I think so. There are pieces that will help people be more comfortable about moving to a more normal cadence of life. But I do think that all of us, having lived through a global pandemic, will be changed forever. And that in good ways, like this has really pushed some fascinating innovation, things like telehealth, and the use of a virtual medium for different meetings. Like it's going to change the way that we do business much more rapidly than anything up to this point. But then there will be some really significant downsides to what this has done to us. And I think that is particularly true about the widening gap in academic achievement, in social outcomes between the haves and the have-nots. And so I think for a long time, we will be trying to figure out how do we come back healthier and stronger from this pandemic.
Well, thank you so much. That is, I think that's a positive note that we're ending on, and I appreciate all the information. My goodness, obviously a lot of questions. We all could not get enough of all the wonderful information you brought to us, and appreciate you being with us today. I'm going to turn it over to Stephen as we close off, but just again, thank you everyone for participating in this very much different version of how we connect and how we share information. And there was a lot shared today. So thank you so much, Dr. Danny Avula. If everyone can show your emojis, wow, okay. And, some hand claps, that would be really great. So we can let Danny know how wonderful we really think he is and how much we appreciate him being with us today. Thank you so much, Danny.
So glad to do it, Yvonne. Take care.
All right, you too.
Thank you guys so much for coming. One last thing, if you do decide you want to come to the drive-in movie tonight, tickets are still on sale on the Innsbruck website. You can also just show up and purchase tickets there, $20 per car, unlimited passengers. We're looking forward to showing A Star is Born from 1937 and having a great time tonight. So Thank you again, though, Dr. Avula. What an awesome time. I can't remember any time we've gone over this much and people still were engaged so much. So thank you so much. Everybody have a great day.
Wonderful. Yay.